Maintaining the head in midline for brief periods is rather typical posture for 2-month-olds, who are just beginning to show anti-gravity activation of the anterior neck and chest muscles. Although at this age, babies don't stay in a symmetrical position for a long time, Marty is able to locate the object and to track from left to right. He is also showing some anti-gravity movements, lifting his lower extremities off the support surface and beginning to demonstrate reciprocal kicking. He is not able yet to reach for toys, even with the tactile cueing of brushing the object against his hand. We should see this evolve in the next 4 to 6 weeks. The tummy muscles are engaged, but not strong enough yet to lift both legs toward the tummy, which is something we should look for by 3 months. In Owen, we see lower muscle tone and more asymmetrical movement. In his head movements, we see more of a predominance of the head turning to the right and less spontaneous head turning and crossing of midline. He is able to latch on to the visual stimuli, the toy, but he can only track as far as the midline and does not turn his head to the other side. We also see much less lower extremity anti-gravity movement. He does not have the endurance and muscle activation to sustain his posture against gravity. His movements are slower, and there is not as much variety in how he's moving his arms and legs. We see much less reciprocal kicking and no lifting of the forearms from the table surface. His movements are much more repetitive, and he has longer periods of inactivity during which he maintains his arms and legs on the support surface. While Marty can't independently roll to the side, he is able to lift his head and upper trunk during a facilitated roll. Initially, he resists the rolling movement, but once he gets into the side-lying position, he shows lateral head righting and the ability to follow through into rolling with head lifted into prone. We also see how Marty demonstrates an integration of the major muscle groups. He can switch from using abdominals during the roll and then recruits neck and back extensors as he completes the roll. Of all the 8 positions we will see, Owen looks most competent in side lying, which is why we recommend looking at the baby in more than one position. This position doesn't require him to work as hard against gravity, so he is comfortable here and looks much more symmetrical. His atypical movement is not as obvious in this position, which lets us know that he has possibilities to produce more organized patterns of movement. He can remain in side-lying position without rolling onto his back, but he does this by strongly flexing his hips and knees, increasing his base of support to counter falling backward. Looking at a baby in all 8 positions will help professionals best determine which course of action, if any, is needed. Here we see some nice head lifting and extension through the thoracic spine. Marty's hips and knees are moving out of the flexed position into an extended, adducted position, shifting his weight posteriorly toward the pelvis area. This frees his upper body so he can lift his head and upper trunk off the support surface. We can also see little weight shifts from right to left, which he's able to counteract with his abdominals to balance himself, all the while increasing his shoulder girdle strength and changing the sensory input on his arms. As his legs progress out of the flexed newborn position, he is able to lift his trunk and begin using his vision to fix on something in the distance. At this age, you should not expect the elbows to be in line with the shoulders, and he will not yet be reaching for toys. We see that Owen has a much more newborn-looking posture, which shifts the weight forward towards the head and shoulder area, making it more difficult for him to lift his head up. He has much more hip and knee flexion than Marty. Once the hips are extended, he will be able to start to lift his head up a little more. It's important to note how changes in the leg position allow the infant to begin developing head and trunk control in the prone position. If Owen does not independently progress to the more extended and abducted legs, he'll be stuck in this position, unable to lift up his head and push up on his arms. His strategy to get any movement is to extend and push up on his legs, which is a non-productive strategy because it doesn't assist him in lifting his head and pushing up on his arms against gravity. When the examiner uses a rattle, Owen gets quiet and listens. But because lifting and turning his head is so difficult when his hips are flexed under him, he is unable to find the auditory stimuli, even though he hears it. When the examiner pulls Marty into a sitting position, Marty demonstrates head lag that one would expect in a typically developing 2-month-old. We see he is able to engage his neck muscles and bring his head into an upright position without it falling forward, and he sustains head control in midline for 10 to 15 seconds. Typical of a 2-month-old, he's not able to assist in the pull to sit, but he is able to generate muscle activity in the shoulder and upper arms to stabilize the upper body. In sitting, he has extension from his cervical spine through the upper thoracic spine. In Owen, we see scapular abduction rather than scapular adduction. We also see little muscle activity in the upper extremities to assist with shoulder stabilization, which results in Owen's head falling forward onto his chest in the upright position. We see very little activity in the cervical spine. Owen's inability to lift his head and push up on his forearms in the prone position is directly related to his inability to use his shoulder girdle to stabilize his upper trunk during pull to sit. We also see rounding through the cervical spine right down into the lumbar spine. We should be seeing the ability to hold his head upright and stabilize with the scapula, and he should have spinal extension through the cervical and upper thoracic areas. Here we see good alignment of the head with the ear directly over the shoulder. There is good activity of the neck extensors. Marty is able to hold and sustain this posture. We don't see a lot of head turning, but this is typical of this age. Marty hasn't yet learned to separate head and trunk extension, but within the next month, this will develop and he will be able to track objects in sitting. We see in supported sitting that the examiner must use more control on the front and back of the trunk to allow Owen to sustain this sitting posture. He has one burst of muscle activity trying to lift his head, but he overshoots the upright position and his head falls forward. This handling position of the examiner is also for safety. The hand on the back is to protect his neck in case he overshoots the upright position. In general, we see he doesn't use his arms. They are very inactive because he lacks shoulder girdle strength to initiate arm movement against gravity. In this position, we are looking to see whether the muscles of the neck and trunk can sustain this posture against gravity, and in Marty's case, they can. When he experiments with moving the entire arm away from his body, we can see that the head control is compromised and falls slightly into flexion. Typical of a 2-month-old, this indicates he doesn't have enough trunk extension to hold the body against gravity without recruiting the muscles in the shoulder girdle to augment the thoracic extension. Unlike Marty, we can see that in this position, Owen is unable to lift his head or activate his neck and his upper thoracic extensors. Instead, he tries to use the same strategy he did before, which is to move his arms and legs to initiate movement. This is a non-productive strategy. Owen needs to develop his trunk strength. Poor head, neck, and core strength is interfering with competence in several postures. When we tilt the baby forward, he not only sustains but increases the head and neck extension. He brings one arm forward, but the left arm is flexed and adducted, close to the body. This posture helps him increase the spinal extension during the forward tip. Marty is on track in demonstrating fundamental control in this position, so that by 6 months he'll be able to extend the head and neck during the forward tip and quickly and easily bring the arms forward to protect himself from contact with the mat. As we tip Owen forward, his inability to lift his head and extend his trunk when being held in horizontal suspension carries over to the forward tipping maneuver. He's unable to generate any head or trunk activity. Without early intervention to develop more trunk strength and optimal movement patterns, it will be highly unlikely that Owen will develop the head and trunk control to allow the mature protective response by 6 months. When placed in supported standing, we see that Marty is able to sustain weight on his lower extremities while the examiner supports him at the trunk. The intermittent bouts of extension and flexion are typical for 2 months. His head is in line with upper trunk, but he is using shoulder elevation and upper extremities held close to the body to assist him in sustaining his head and trunk posture against gravity. There's a good vertical alignment from head through trunk down to the feet. When Owen is placed in standing, he is only able to sustain pseudo-extension when the examiner is providing maximum support and lifting. He has no intermittent muscle activity to attain or maintain the standing posture. Every time the examiner tries to let him take weight on his feet, he collapses into flexion.
The Bahamas Neurological Center, established since 1999, the only facility in the Bahamas that offers comprehensive neurological, neurodiagnostic, and neurorehabilitation services at the one locale. Dr. Edwin Demerit, the only pediatric neurologist in the Bahamas, one of the 3 adult neurologists here in the Bahamas, and he is also a neurophysiologist. BNC is the first comprehensive neurological clinic in the Bahamas and the only multidisciplinary facility in the Bahamas that caters to the English-speaking Caribbean region. Our mission is to provide our local and worldwide customers with qualified medical providers and administrators who can deliver world-class standards of service and products within the Bahamas and Caribbean region while promoting our customers' good health and overall well-being. BNC and its affiliates is a multidisciplinary group whose goal is to become the premier provider of neurology consultation, testing, treatment, rehabilitation, and training services within the Bahamas and the Caribbean region. Bahamas Neurological Center offers neurology consultations for adults and pediatrics, specializing in epilepsy, traumatic brain injuries, multiple sclerosis, Alzheimer's disease, carpal tunnel syndrome, sleep disorders, cerebral palsy, brachial plexus injuries, and learning disorders.
Marty is able to maintain his head in midline for long periods now. Midline and symmetry of the head, eyes, arms, and legs is the hallmark of the supine position in 4-month-olds. He demonstrates interest in exploring objects with his hands. Marty is very visual in both horizontal and vertical planes, which leads and drives his movement. There's movement in the forearm, wrist, and individual fingers as he remains visually engaged with the object. His legs bang down on the surface, typical at this age. Extremity movement disassociated from trunk movement is more evident with frequent anti-gravity extremity movement. Babies at this age often can't combine the movements of hands and feet, nor are they always able to coordinate their reach with their vision. When the feet are moving, the hands may be still, and vice versa. By 5 months, we should see Marty consistently moving both hands and feet together, and better able to combine reaching movement with his ability to localize and track an object. Owen still shows much more asymmetry of both the head and extremities than is expected at 4 months. Owen's head is turned to the side, and he shows more activity on the left side of his trunk. Rather than being in a straight line, his body is curved like the letter C. He relies on extension rather than a balance of extension and flexion. The movement associated with repositioning disturbs and disorganizes Owen. It takes him longer to reorganize, though he calms down when reassured. He exhibits random movements in his arms and legs. However, there's not much anti-gravity movement. He appears to be attending to the toy and is moving both arms on the surface, but not lifting his shoulder off the surface as expected. When facilitated into a side-lying position, Marty follows along with his upper arm and disassociated lower extremities and is able to sustain the posture, indicating a solid balance of trunk flexor and extensor muscles. He is able to lift his head and upper trunk off the support surface, which is a precursor to being able to roll independently onto his tummy. Babies who can't lift their head and upper trunk usually have trouble rolling, or use a less optimal rolling strategy of excessive neck and trunk extension. Owen does not have the same ability to sustain the side-lying posture as Marty. The top arm is sluggish in its ability to be used to assist in the rolling maneuver. Owen does not lift his head off the support surface to begin head righting, though we would expect a 4-month-old developing typically to demonstrate this response. Owen demonstrates inadequate control in side-lying and in rolling onto the back. Marty is able to get his shoulders and upper arms forward. With his head lifted to 90 degrees, we see extensor muscle activity down into the lumbar spine. His lower extremities still show some flexion and abduction, but he is moving toward exhibiting lower extremity extension. He is beginning to take weight on fisted hands, typical for this age. He is able to turn his head freely and follow a toy side to side. As he turns his head and starts pushing, we can see that this push causes a weight shift to the right side. This will help further extend his leg and let him start the initial movement to rolling onto his back. Notice that the elbows are in front of the shoulders, creating a narrower base of support. Marty is also able to reach forward on the surface for a toy. The ability to bring the arms forward and prone is important because it helps facilitate rolling onto the back. Much as we saw at 2 months, Owen's hips are too flexed, which causes weight to be shifted forward to his shoulders and head. His elbows also remain behind his shoulders. These movement patterns interfere with forearm propping. Owen can lift his head clear of the surface just enough to turn it from one side to the other. He cannot sustain head lifting, however, and he uses only neck extension to turn. Owen is unable to use upper extremity control to shift weight posteriorly onto stable lower extremities, which would provide greater stability for his head and support upper extremity weight bearing. Marty starts out with his head in midline. He shows that he's able to lift his legs and activate his trunk muscles. As he moves towards sitting, we see his head in line with his body from 15 to 30 degrees from upright. There is no delay, no head lag. He has good chin tuck of at least 45 degrees. Throughout the maneuver, he is able to help a little by pulling with his arms. By the end of the movement, he is pulling himself forward with his abdominals, and he doesn't have full activation of the lumbar spine. Owen demonstrates head lag throughout the entire maneuver. Owen does not assist in the pull to sit by pulling with his arms. In fact, there is little to no upper extremity participation throughout the maneuver. He does not appear to anticipate the movement toward the upright position. In supported sitting, we see that Marty is moving into the anterior-posterior planes as he reaches for toys and then sits back up. He's able to pick up this small toy and bring it to his mouth. We see good head control and chin tuck, with head in midline. Babies of this age often reach with one hand, using the other upper extremity for stability until full postural control is developed. His body is supported only at the hips and pelvis. We see extension down to the mid-thoracic spine. Full extension down to the lumbar spine will not be present until 6 months. Even with minimal support at one shoulder, Marty is able to turn his head quickly and easily to localize and grossly follow the toy in all directions without losing his balance. In supported sitting, Owen exhibits a momentary burst of head lifting in midline, but he is unable to maintain that head position for even the briefest period of time. He is unable to turn his head or look side to side, even when the examiner provides support at the upper arm and shoulder. The examiner holds him high under the armpits for maximum assistance. Owen has difficulty activating his vision in this position, unlike Marty, who is able to visually fixate on and begin to track a toy. The extremity movement that Owen demonstrates is used to compensate for his decreased strength, control, and stability in the head and trunk. In horizontal suspension, Marty is able to keep his neck and trunk extended as he is tipped forward. He maintains his head upright to 45 degrees above horizontal, holding it steady in midline through the whole maneuver. He shows good trunk extension with scapular adduction, but he is able to freely move his arms and legs in this position. He has trunk extension into the lumbar spine. Owen is able to hold his head up briefly during horizontal suspension, but unable to maintain it in midline. Owen does not demonstrate sustained thoracic trunk extension in this position, and he is unable to extend his hips, indicating poor core strength and stability. Unlike Marty, Owen is unable to sustain the neck and trunk extension when moving his arms and legs. Marty has good extension through the neck, trunk, and hips, and he is able to maintain that extension during quick forward tilting in space. However, because he is using his arms to help him sustain trunk extension, he cannot bring them forward into a full protective response, which should be present by 6 months. Within the next 2 months, he will be able to sustain head and trunk extension throughout the forward tilt without the assistance of his arms, resulting in the full upper extremity protective response by the end of the maneuver. Although a mature protective response is not fully developed until 6 months, even at 4 months, Owen is unable to sustain strong neck, trunk, and hip extension during forward tilting. However, there is adequate neck extension to prevent his head from coming in contact with the surface. To sustain neck and trunk extension, he either uses excessive asymmetry or flexes his arms into his chest to increase the tone in his trunk. When Marty is placed in supported standing, his hips are just behind his shoulders, which puts his ankle into relative plantar flexion. He demonstrates extension in his trunk through the lower thoracic and lumbar spine, but cannot yet achieve full hip extension. By 6 months, Marty's hips should be fully extended, creating a vertical line from his shoulders through his hips, knees, and ankles. Marty can sustain this posture with the examiner holding his lower trunk. He doesn't require assistance to support his weight, but rather to maintain his balance. Marty can maintain his head in midline for an extended period of time or move it freely. Owen is readily able to take weight on his lower extremities, but intermittently flexes at the hip and knees. Owen's shoulders are still well in front of his hips. By 4 months, active trunk extension toward a more upright alignment is expected. Unlike Marty, who is able to sustain standing with support at his lower trunk, the examiner must hold Owen in the upper thoracic area to assist him in maintaining the standing position. Head lifting is achieved using neck extension, but this extension is intermittent. Owen lacks adequate hip and trunk control for sustained supported standing.
The Bahamas Neurological Center, established since 1999, the only facility in the Bahamas that offers comprehensive neurological, neurodiagnostic, and neurorehabilitation services at the one locale. Dr. Edwin Demerit, the only pediatric neurologist in the Bahamas, one of the 3 adult neurologists here in the Bahamas, and he is also a neurophysiologist. BNC is the first comprehensive neurological clinic in the Bahamas and the only multidisciplinary facility in the Bahamas that caters to the English-speaking Caribbean region. Our mission is to provide our local and worldwide customers with qualified medical providers and administrators who can deliver world-class standards of service and products within the Bahamas and Caribbean region while promoting our customers' good health and overall well-being. BNC and its affiliates is a multidisciplinary group whose goal is to become the premier provider of neurology consultation, testing, treatment, rehabilitation, and training services within the Bahamas and the Caribbean region. Bahamas Neurological Center offers neurology consultations for adults and pediatrics, specializing in epilepsy, traumatic brain injuries, multiple sclerosis, Alzheimer's disease, carpal tunnel syndrome, sleep disorders, cerebral palsy, brachial plexus injuries, and learning disorders.
Immediately when the toy is presented, Marty reaches voluntarily. We see him bring his hands to his feet, and at 6 months, we would also see hands to knees and feet to mouth. These movements help to mobilize the pelvis and increase pelvic femoral mobility. His lower extremities are still abducted and externally rotated. Marty is able to symmetrically lift his upper and lower extremities against gravity while simultaneously investigating the ring. Marty exhibits disassociated upper and lower arm movement as he grasps and explores the toy by turning it over several times in a well-coordinated motion. Owen's ability to hold his head in midline has improved since we last saw him at 4 months. However, he rarely demonstrates anti-gravity movement, and little abdominal activity is evident despite his apparent visual attention to the toy. Improved abdominal activity would provide the core control to allow anti-gravity flexion toward midline. Owen's extremities are abducted and externally rotated with occasional hip flexion and extension during kicking movements. Owen's upper extremities are also abducted and externally rotated with movement primarily on the surface. With assistance in positioning his lower extremities and activating his abdominals, Owen is able to briefly maintain his knees up toward his chest and in midline. He is then able to initiate a burst of active abdominal flexion, lifting his pelvis off the surface. However, he is unable to maintain, grade, or play in this position as expected at this age. Marty visually follows and reaches, then rolls independently and easily through side lying into prone, initiating the movement with his lower extremities. Both the side-lying posture and the movement through side-lying to prone provide Marty with increased asymmetric tactile input, which is important for eliciting proper head and body righting reactions. Marty chooses not to stay in a side-lying position as he is too interested in play and exploration. Owen's arms rest in a position of passive wide abduction. Owen visually engages with the toy presented, but this visual interest does not translate into arm movement, even as the examiner attempts to facilitate rolling from back to side. Even when the examiner attempts to entice him with a toy, we see the shoulder extension preventing rolling forward to his side. Owen's unbalanced neck, shoulder, and back extension prevents forward movement of the head and arm to assist rolling to his side. Here we see Marty on extended arms, supporting his weight while turning his head to follow the toy. With increased weight bearing on extended arms, Marty has developed increased extension down to the lumbar spine and hips. This also brings his lower extremities into a strong, extended position. Prone pivoting in an attempt to obtain a toy is also seen. In this maneuver, Marty demonstrates disassociated movement of both the upper and lower extremities, which aids in right-left stability and control. Increased scapulohumeral disassociation is evident in weight bearing and weight shifting. The quick and immediate use of reach and grasp upon presentation of an object allows for many opportunities to improve control and coordination of both the shoulder and hand. Marty participates in varied play schemes of banging, turning, mouthing, transferring, and repeating sensory motor exploration with his hands. Marty also demonstrates a palmar grasp with increased digital participation, including thumb abduction and extension. By 6 months, the prone position is typically chosen for play due to greater head, shoulder, and trunk control. Here we see that Owen is still greatly challenged when prone. He demonstrates lower extremity kicking but does not possess the stability required for upper extremity play. Owen still positions his elbows behind his shoulders, making it very difficult for him to use his upper extremities to assist in head and trunk lifting. Without adequate stability, Owen is unable to use his vision or hands to explore his environment. When pulled to a sitting position, Marty is able to respond quickly, and he assists in the maneuver by actively flexing his neck forward and lifting his head from the support surface. He also uses activity in the upper extremities and abdominals to assist in the pull to sit. At 6 months, Marty is able to efficiently assist in the pull to sit and attain this position with good symmetry. Unlike Marty, Owen is only minimally able to assist in the pull-sit maneuver and demonstrates complete head lag until he reaches the upright position. Though we would expect a 6-month-old to assist with upper extremity pulling, we do not see this response present in Owen. Once upright, he is then able to right his head and hold it in midline briefly before it falls into lateral flexion. Now at 6 months, Marty has stable head and trunk control with strong extension through the thoracic spine. Marty is able to reach with one arm at a time, as his wide of support gives him greater stability in the lower extremities and freedom of upper extremity movement. With emerging postural control against gravity in sitting, Marty is also able to lean forward, reach, and then re-right his trunk over his pelvis to attain the upright sitting position. He is also able to sustain a gross grasp on objects while utilizing a variety of upper extremity movements, though these movements are still ungraded in the sitting position. As we saw at 2 and 4 months, Owen is willing to maintain his head upright and in midline when held in supported sitting. The examiner must still support him high in the chest to allow him to sustain his head upright. His trunk extension is poor, and he does not have a solid balance of trunk flexor and extensor muscles to stabilize himself. His upper extremities come down to his sides, but Owen's ability to activate his vision and his reach to explore are not observed, as he needs to work so hard just to remain upright. Marty now demonstrates full sustained extension in his neck and upper thoracic spine, which continues down through the hips and legs. This is precisely what we would expect when testing horizontal suspension in a 6-month-old. Owen is able to lift his head symmetrically in midline and extend through the upper thoracic spine and hips. He maintains the response only briefly. Protective extension is easily and quickly elicited as Marty is tipped forward towards the surface. He props immediately on one upper extremity and is already active with the opposite extremity, reaching for a toy in front of him. When attempting to elicit a protective response, Owen does not bring his upper extremities forward to the surface to protect himself. A full protective response would be expected by 6 months. His decreased anti-gravity neck and trunk strength makes it impossible for Owen to sustain the head and trunk extension needed to free the arms to come forward during this maneuver. Marty demonstrates immediate sustained weight bearing on extended lower extremities. His hips are still slightly flexed and somewhat behind the shoulders. His head is free to turn and look around, and his arms are coming down to his sides. The upper extremities are still assisting in the posture, as evidenced by the strong upper thoracic extension. Owen does not initiate or sustain weight bearing when placed in supported standing. We have seen in nearly all the anti-gravity positions, head and trunk control are still a challenge for Owen. This inability to sustain weight bearing makes it impossible for Owen to develop control in standing because he is unable to align his head, trunk, hips, knees, and feet in the vertical.
The Bahamas Neurological Center, established since 1999, the only facility in the Bahamas that offers comprehensive neurological, neurodiagnostic, and neurorehabilitation services at the one locale. Dr. Edwin Demerit, the only pediatric neurologist in the Bahamas, one of the 3 adult neurologists here in the Bahamas, and he is also a neurophysiologist. BNC is the first comprehensive neurological clinic in the Bahamas and the only multidisciplinary facility in the Bahamas that caters to the English-speaking Caribbean region. Our mission is to provide our local and worldwide customers with qualified medical providers and administrators who can deliver world-class standards of service and products within the Bahamas and Caribbean region while promoting our customers' good health and overall well-being. BNC and its affiliates is a multidisciplinary group whose goal is to become the premier provider of neurology consultation, testing, treatment, rehabilitation, and training services within the Bahamas and the Caribbean region. The Bahamas Neurological Center is the first in the Bahamas to do ambulatory, video, and digitalized EEGs. We are also the first in the Bahamas to do sleep studies. First in the Bahamas to do evoke potentials, visual, brainstem auditory, and somatosensory. Bahamas Neurological Center is also the first in the Bahamas to do newborn hearing screening. Bahamas Neurological Center offers neurology consultations for adults and pediatrics, specializing in epilepsy, traumatic brain injuries, multiple sclerosis, Alzheimer's disease, carpal tunnel syndrome, sleep disorders, cerebral palsy, brachial plexus injuries, and learning disorders.